The basic knowledge of the prostatic anatomy is important before we dwell into the MR characteristics of prostate CA. The prostate has 4 zones: a peripheral gland, a central zone, and a transitional zone that comprises of the central gland, and this is no longer now recommended by the ACR, and there is an anterior fibromuscular stroma. So the prostate, there is a peripheral zone which is about 75%, the central zone and the transitional zone. During the prostatic hyperplasia or hypertrophy, the transition zone becomes hypertrophied and compresses the peripheral zone. In description of the prostatic anatomy in MR, the prostate is divided into thirds in the craniocaudal direction with the base, a midgland, and apex, and to the right and the left side. So while describing the prostatic lesion in MR, you describe it as whether it's the right base, right midgland, left midgland, right apex and left apex, and so on. So in the coronal sections, this is the base, the mid-body and apex. It is like a truncated cone. And you describe the prostatic lesion as the right mid-body, left mid-body, and the right apex or the left apex. And in the axial sections, you see the seminal vesicles and the neurovascular bundles, which will be in the 5 and the 7 o'clock position. So basically, several diagnostic modalities are available for evaluation of prostate. A PSA may be used, a truss and a biopsy can be used, a CT scan is available, MRI, bone scintigraphy, a PET scan is there, and now a PSMA scan is also available. Basically, a truss alone has very poor test characteristics to diagnose a prostatic CA with a positive predictive value of about 52.7%, an accuracy of 67%, while in combination with sextant biopsy, the false negative rate still exists, is about 34%.